This clinical view shows a typical right upper free end situation distal to tooth 5. This is also seen on the OPG. The bony wall separating the oral cavity from the maxillary sinus is presumably 2 to 5 millimeters thick. On the left side, there is evidence of a sinus lift years ago. CT scans confirm these findings and suggest that the wall separating the oral cavity from the sinus is about 2 millimeters thick. This is confirmed by baseline 3D images. The sinus floor is seen to be smooth. In the planning process, the position of the implants is defined and a surgical splint is fabricated. With it in place, another set of CT scans as well as an OPG is recorded for measuring the distance from the coronal margin of the guide sleeves to the alveolar recess and to the lowest point of the sinus floor. These data are used for fabricating the definitive surgical splint. The procedure is performed in local anesthesia. The prefabricated surgical splint is placed in the mouth. Once well aligned, it will determine the drilling direction and depth. The first instrument to be attached to the angle piece is a soft tissue burr. This is introduced into both holes of the surgical splint and pushed down until it is locked to prepare a soft tissue canal down to the occlusal surface of the alveolar recess.
Okay.
Then a guide selected from the Nobel Guide Kit is secured to the titanium sleeve of the surgical splint into the mesial hole to control drill handling. Meanwhile, the soft tissue burr in the surgical angle piece is replaced by a gun drill. A spacer ring chosen on the basis of the radiologic measurements is slipped over the gun drill to prevent it from penetrating beyond the sinus floor. On the endoscopic view, it can be seen to have just pierced the bony wall without injuring the sinus membrane. In the next step, a specially designed needle is inserted into the drill hole. It features a bulge at the tip which can be inflated by turning the wheel. This seals the drill hole. The wheel is initially turned with a fingertip and then with a forceps.
Okay.
When the needle is secured, a syringe filled with a gel and an X-ray contrast agent is attached to it. Turning the piston of the syringe ensures that the gel is injected deep to the sinus membrane at a constant pressure. Once this is completed, the needle is withdrawn from the mesial hole in the splint. Then another drill guide is selected from the Nobel kit and inserted into the distal hole of the splint, and a hole is drilled down to the sinus floor with the gun drill. The length of the gun drill chosen should ensure that the sinus membrane is just reached with the instrument. Like mesially, the needle is now inserted into the distal hole of the splint, and the wheel at its base is turned to inflate the bulge at the needle tip for sealing the drill hole.
Ja, es geht dabei um 2-3 Bewegungen.
Ja, wenn man es einmal hat.
Das andere kann man dann wegschieben.
Once this is done, the gel with the contrast agent is injected deep to the sinus membrane by turning the piston of the syringe. The insert shows that all of the sinus membrane can be elevated in this manner without injuring it. The wheel on the needle is then released so that the splint can be taken out of the mouth. The intraoperative dental radiograph shows the space deep to the sinus membrane to be filled with gel plus contrast agent. The membrane itself is apparently intact. This is confirmed by the escape of the gel through the drill holes in synchronicity with breathing. In the following step, the water-soluble gel plus contrast agent is washed out with physiologic saline. Note that irrigation through one of the drill holes forces the fluid out through the other drill hole. This signals that the spaces created at the level of the sinus floor superior to the two drill holes communicate. Irrigating fluid can still be seen to be forced out through one of the two drill holes.
Wir fühlen schon, gell? Kommt schon der Knochen hinein. Und dann kommen noch die Implantate, also ein bisschen dauert es schon noch. Jo.
Marianne?
Now is the time for injecting bone replacement material through the two drill holes with the help of an adapter. The packing material is pushed upwards in portions and condensed. This maneuver is repeated several times. Once the void is completely packed, implants can be placed.
Ja, das sind ganz kleine Portionen. Nein, ohne Schütteln. Kann das sein, die Schleimhaut liegt hier? Okay. Okay. Kopf gerade, Kopf gerade.
In the given case, select tapered regular platform implants by Nobel Biocare with a length of 10 millimeters were chosen.
Kann man vertrauen. Das ist herausgeräter.
Auf 10 schalten. Okay.
These are seated with a torque of 40 Newton per centimeter. After checking if they're seated at the right depth, healing abutments are screwed down on them. Suturing can be omitted. A healing time of 4 months will be allowed before 2 single crowns are attached. The efficiency of the procedure is confirmed by the radiograph. The alveolar recess can be seen to be well packed with bone replacement material. The implants were placed in the right position as planned. This is also seen on the post-operative CT scans. They show both the implant site and an area well packed with bone replacement material mesial and distal to it. Superior to it, the sinus membrane, which was already slightly thickened preoperatively, can be seen to be moderately endematous. Post-operative 3-dimensional reconstructions confirm what has been described above. As mentioned, the alveolar recess is well augmented.